and Tony waste of time.
Okay, good evening. I think we'll start. Thanks all for coming tonight. My name is Shauna Blois. I'm one of the small animal internal medicine folks here at OBC. And our service is combining with nutrition and soft tissue surgery tonight to hopefully cover some topics in the urinary tract that seem to be challenging for us. Before we start, I'd like to acknowledge the sponsorship that Boehringer Ingelheim has provided tonight for the lunch and for the talk. We have a rep from Boehringer tonight if anyone has any questions, especially on their new drug, Symentra. But I'd just like to thank them very much for providing us with the dinner tonight and their support for OBC. We're going to start off tonight with a topic that seems to be becoming more prevalent at OBC and at referral clinics around our area. And we're dealing with a lot more cases, it seems like, of upper urinary tract ureterolithiasis and nephrolithiasis. So these stones in the upper urinary tract seem to create a lot of issues because up until about maybe 5 or 6 years ago, we didn't really have great options or great knowledge about how to treat these cases. And so the really nice thing about presenting this as a topic is that we really combine a lot of different people in the OBC small animal clinic as far as getting a lot of different opinions on these cases. And so it really is a combined effort when we're dealing with these with small animal internal medicine, soft tissue surgery, and the nutrition services. So before I start, I just wanted to introduce the folks that are here tonight from OBC, because we speak with a lot of you on the phone. If we haven't met you before, we'd love to meet you afterwards to put a face to the name and the voice on the phone. And also remind you that we're always available. We do free advice calls and faxes, so certainly use us if we can help you with your cases. We have Dr. Tony Abrams-Ogg in the very back. Sorry, Tony, to start with you. The voice that, if anyone calls the internal medicine service, probably the person that you speak with the most is Allison Downey, super technician. And Allison, a few years ago, was one of the first technicians in Canada to be certified as a small animal internal medicine specialty technician. So very knowledgeable and awesome for our team. Catherine Vachon is sitting beside Allison. Benoit Cook, 2 of our residents. Shannon Westgarth is down here. Sorry, Shannon. Our 3rd-year resident. Jackie Parr is here from the nutrition service. We have Julie Lemetayer, who is one of our newer small animal internal medicine faculty members, and Danielle Richardson, who is in small animal internal medicine and oncology. And then way in the very back, hiding from all of us, is Amit Singh from the small animal soft tissue surgery service, and Michelle Oblak will be joining us as well. And Sophie, there you are. So the forgotten resident, Sophie Sati. I'm sorry, Sophie is there as well. She's one of our residents. I love her. I'm sorry. Wonderful. Okay. So the first part of tonight, we'll talk about nephrolith and ureterolith and how these cases present. And because we commonly see them in cats, we'll focus a little bit on the cat cases, but also draw some comparisons with dogs as well. Specifically aiming on diagnosis and then also on management options. And like I alluded to, the management is very multimodal. So this will bring into the conversation surgical folks as well as nutrition options. So we're starting to notice more and more, either incidentally or clinically, calculi either in the renal pelvis, the collecting system, or in the ureter on radiographs or on ultrasound in the canine and feline patients that we see. When you look at the data, in some studies, 3% of uroliths submitted to the Medi-Cal or the other urolith analysis centers are from the upper urinary tract. Other studies will cite 5 or 7%, but really a small proportion of the uroliths that we're seeing in clinical practice reflected in those studies seem to be from the upper urinary tract. Likely that's an underrepresentation. A lot of the nephro and the ureteroliths that exist in dogs and cats are asymptomatic. So potentially we're not diagnosing a lot of those cases. And then also because those uroliths are so difficult to retrieve, not a lot of them are going to get later sent off for submission. So likely in the literature that 3 or 5 or 7% of uroliths coming from the urinary tract or upper urinary tract is likely a very low representation of the true prevalence or incidence of those. And so true incidence is actually unknown. Now, a lot of these cases will be asymptomatic, but when we think about starting to obstruct either the ureter or the kidney itself, that pressure damage can cause a lot of different things. The stone can serve as a nidus of a bacterial infection, so these cats and dogs can be predisposed to pyelonephritis. We can start to have ischemia from just pressure buildup from the urine and the fluid not being able to exit the ureter and into the bladder. And so we can have ischemia and acute kidney disease. And we can also have later effects, so chronic kidney disease effects in those cats and dogs with obstructions, partial obstructions in these cases. So that's what partial obstruction would result in. Complete obstruction, we do see that sometimes, will result in either very acute signs of renal pain, or every now and then we'll find a cat or a dog with a kidney that is just, the tissue is just obliterated from a complete obstruction of a urinary, upper urinary tract stone. And so even those can be incidental in findings. So composition of the stones that we see in the upper urinary tract can be variable depending on what species we're dealing with. In cats, up to 98% of those stones are going to be calcium oxalate in origin or calcium-based from another calcium type product. Only about 8% or up to 8%, depending on the study that you're looking at, are going to be struvite. So majority of cat upper urinary tract stones are going to be calcium-based. In dogs, right now, based on the submissions that occur, it seems like it's about a 50-50 split between calcium oxalate and struvite, either ureteroliths or nephroliths. But again, because we're not able to submit or retrieve a lot of these stones, potentially that could be a bit of an unknown origin as well. The signalment that we see for cats is pretty variable. So cats that are presenting with nephroliths and ureteroliths, they can be either male or female. Domestic short hair, domestic long hair, in the literature anyway, seem to be most commonly represented. But that being said, they are also in most clinics the most common cats that are coming in. Usually they're middle-aged to older. So the case that we had on Friday with ureteroliths was a 9-year-old cat, very typical presentation age for these cats to come in. In dogs diagnosed with nephroliths or ureteroliths, females tend to be a bit more predisposed. There are a few breed predispositions. Miniature Schnauzer is predisposed to everything, so no surprise that that dog is on the list, but also other smaller breeds too, Lhasa Apso, Shih Tzus, Yorkies, so any of those little breeds that are trying to be cats, maybe in their own ways. Most of the dogs that we see, similar to the cats, are middle-aged to older as well. One of the challenging things about diagnosing these conditions is that we have such a wide spectrum of clinical signs, and clinical signs can be very vague. So in some cases, these might be incidental findings on radiographs or ultrasound, and these cats and dogs will be asymptomatic. In other cases, especially in cats, the signs are very nonspecific. So cats seem to have a spectrum of about 3 clinical signs that they'll show for any illness. Upper urinary tract ureteroliths and nephroliths are included. So vomiting, anorexia, lethargy, very common presentation for these conditions, but again, very nonspecific, so not really helping us a lot with our diagnosis. And if there's any questions that come up, please don't hesitate to raise your hand or speak out if there's anything that's unclear. For physical exam, again, depending on how symptomatic these patients are, might have very few clinical signs. In other cases, we can have elevated temperature, especially if we start to have infections associated with these nephroliths or ureteroliths. Abdominal pain, again, could also be appreciated. And one or both kidneys can be enlarged, especially in the acute phase of more complete obstructions, because those kidneys start to develop hydronephrosis or acute kidney injury. In very chronic cases, when chronic kidney disease starts to take over, potentially one or both of those kidneys could also be quite small. So in the workup of these cases, if blood work is done, a lot of the abnormalities are quite consistent with either an acute or a chronic kidney insult. So we can have electrolyte abnormalities, so hyperkalemia from urinary blockage. We can have elevated phosphorus levels. Very common to see azotemia. And then in more chronic cases, especially when the anemia is severe or chronic kidney disease is quite progressed, we can see anemia as well. A mild anemia could also be consistent with an anemia of a chronic disease. So up to half of the patients will have a urinary tract infection when they're diagnosed with their ureterolith or their nephrolith. It varies a little bit by species, which I'll get into in a moment, but very common to see an active sediment on the urinalysis, so red cells, white cells, potentially some crystals, bacteria, protein, very common as well. And culture is a good part of the workup for these suspected cases too. So most of the cases that we see will often start out with abdominal radiographs as one of the front lines for imaging. And rads can tell us a lot, especially for radiopaque stones. And in the cats, we have a really good chance of these being calcium-based, so they're often radiopaque. Location and number of stones vary. In some cases, very easy to tell based on the radiographs and based on the size of those stones. But when you start to look for the ureters, colon is often very inconveniently located on those radiographs. And so the colonic material will often overlap where the ureters are and really obstruct our ability in some cases to identify ureteroliths. Nephroliths a little bit less challenging because colon doesn't necessarily overlap as much, but still other viscera and feces can make interpreting the radiographs a bit of a challenge. So for those reasons, sensitivity of radiographs, not going to be 100%, but very good to help in most cases identify ureteroliths, nephroliths, and also be able to count those. Got an example of one of our patients. His name is Grinch. He's a cat, and one of our chronic patients. And on his lateral radiograph, when he first presented, we could see a nice nephrolith here in his kidneys, and then also likely some ureteroliths tracking down to the kidneys. So ureters are typically going to run along that path down to the bladder, which is very similar to where the colon can be. This is from one of our colleagues at OVC, Elise Defarge, published a review on ureteroliths and nephroliths a few years ago in Compendium. And this is one of the images that she had in her publication of another animal with a nice nephrolith, and then downstream many ureters. And we can really see here that the feces-filled colon can start to overlap with that track of the ureter, and so potentially obscure view when the ureteroliths are not that obvious. These are pretty honking ureteroliths in this animal. They're not always as friendly to diagnose. They're often a lot smaller than that, especially in cats. And so these ones are nice, nice ones to look at. A lot of these animals, after seeing nephroliths or suspecting nephroliths and ureteroliths, will undergo an abdominal ultrasound. We can see a lot of different changes on the ultrasound depending on the phase of the disease that these animals are in, and also the degree of obstruction that ureterolith or nephrolith is causing. Depending on if we have downstream obstruction of those ureters and how complete it is, hydronephrosis and hydroureter can be very common findings. And as I mentioned before, depending on the chronicity of the problem, you can either see some signs of acute kidney injury or chronic kidney damage with the pressure buildup in those kidneys upstream from the urine obstruction. Uroliths, to me, can be very challenging to find. I don't think I would have a hope of finding a ureterolith on ultrasound on a good day, but depending on your skill as far as an ultrasonographer goes, I think nephroliths and ureteroliths can be visualized in a lot of cases. Usually radiographs and ultrasound are used as complementary diagnostics, so pairing those up gives you the best sensitivity for identifying these stones. So a couple more images from some of our patients. So Grinch, the cat from the last radiograph, this is a sagittal view of one of his kidneys, and we can see a nice dilation of his renal pelvis in his right kidney here. Another one of our patients, Cleopatra, shows the extreme version of renal pelvis dilation to the point of a pretty drastic hydronephrosis, where she had only a rim of kidney tissue left on her ultrasound of one of her kidneys here on her left kidney. We can see just a really tiny bit of kidney here, and then a nice black hole where the kidney should be. And both of these patients also had very proximal ureteroliths. So just as you're exiting the kidney, or just as the ureter is attaching to the kidney, we can start to see some mineral shadowing here and some very opaque material on ultrasound, diagnostic likely of ureteroliths in both cases. So for Grinch here, and then for Cleopatra down here. In most cases, radiographs and ultrasound in combination, or sometimes just radiographs alone, are enough to help us achieve the diagnosis of either nephrolith or a ureterolith. And depending on how much intervention your patient needs, sometimes if the location and the extent of the obstruction is difficult to determine, and these are surgical candidates, other diagnostics like pylography might be performed. But these are reserved for a few cases where it's a bit more challenging to see their obstructions, and these are usually reserved for surgical candidates for surgical planning. And not all patients are necessarily going to undergo that type of imaging. Any questions so far on the diagnostic part of things before we get into treatment? Okay, so we'll start with nephroliths first. Nephroliths are nice because in most cases, they are very inactive. And so in a lot of patients, we're able to monitor those inactive nephroliths and not necessarily have to intervene with big interventions. In dogs, because about 50% of those can be struvite, potentially medical dissolution might be an option. Surgical removal in some rare cases may be considered. And then shockwave lithotripsy, extracorporeal or outside of the body shockwave therapy is sometimes performed for nephrolith to dislodge those nephroliths. Not a lot of studies done on shockwave lithotripsy for nephroliths and especially ureteroliths, and the numbers, the success rate is quite poor, so it's not commonly performed. So most of the patients that are noted with nephroliths, especially if they are clinically asymptomatic, will be managed very conservatively, just with a monitoring plan. And the nice thing to know is that in one study, at least, of cats with chronic kidney disease, they found that the cats that had nephroliths did no worse than the cats that didn't have nephroliths. So having a nephrolith or having a few nephroliths does not influence the prognosis in cats with chronic kidney disease. It might increase, rate of infection or things like that, but overall outcome, survival, and quality of life doesn't seem to be influenced by presence of nephroliths. So one of the complications that it's recommended to monitor these cats for and dogs for with nephroliths would be a pyelonephritis. Some of the things to consider about nephroliths in general would be that their presence, depending on if they are obstructive, could compromise the renal function over time, especially if there is some obstruction. In some cases, there is pain associated with nephroliths, not always, but in some patients there is. And then there are some reports of being able to track a nephrolith rolling down to the ureter, causing some partial obstruction, and then rolling back, depending, I guess, on how the dog or cat is lying, rolling back to the kidney. And so going back and forth and creating an intermittent ureteral obstruction. So this is something that could potentially occur. More common when, obviously, the nephrolith is in the renal pelvis versus actual tissue mineralization or a nephrolith within the embedded within the tissue of the kidney. That one isn't going to be likely to roll around. But the nephroliths within the renal pelvis that are small enough could potentially trickle down and roll down into the ureter and cause some ureteral obstruction. So as I mentioned before, ballpark about half of our patients with nephroliths or upper urinary tract uroliths will have urinary tract infections. So actually 75% of dogs in some studies, or up to 75% of dogs in some studies, will have a UTI at the time of diagnosis. Not as many cats, so about 10 to 30% of cats will have a UTI when they have a nephrolith or a ureterolith. And so for that reason, it's very common and recommended to do a urine culture and sensitivity in cases when we do diagnose these. We know that sometimes downstream shedding into the bladder or collecting urine from the bladder might not necessarily give you a diagnostic result if there is a pyelonephritis, because the shedding of the bacteria can be intermittent, but it's a good place to start, and especially when the renal pelvis isn't dilated very much, it's a lot more technically feasible to obtain a cystocentesis rather than trying to get a sample directly from the renal pelvis. Most common bugs, at least, are fairly consistent between staph, strep, E. coli, and Proteus. So it can be easy to choose empirical therapy for antibiotics before getting your culture and sensitivity results back. Looking at treatment times for managing these concurrent UTIs in the face of an upper urinary tract stone, for pyelonephritis cases, so when you have a nephrolith, azotemia, and potentially clinical signs that are supportive of pyelonephritis, that could be fever, it could be other signs of systemic illness. In those cases, we consider that pyelonephritis is present, and for those patients, really long antibiotic treatment time, so 6 to 8 weeks of treatment duration. For ureteroliths, general recommendations would be similar treatment times, again, extended antibiotic treatment times, about 4 to 6 weeks of treatment. And then ideally, and understanding that this is not possible for all of the clients that we deal with, ideal monitoring would be to reculture the urine from the bladder every 2 weeks while these patients are on treatment, because they can develop some resistance or they can have multiple bugs present. And again, ideally 1 week after completing the antibiotic therapy regimen, it would be very nice to culture to make sure that we've actually cleared that infection. So in dogs, about half of the patients with upper urinary tract stones will potentially have a struvite stone. And so it is possible to attempt medical dissolution of those stones, understanding that upstream, either in the kidney or the ureter, we're not going to have continued bathing. It's going to be a bit more intermittent bathing of those stones with urine. So potentially with our therapy, we're not always going to achieve medical dissolution for either a nephrolith or a ureterolith. But in the face of that versus surgery, it's a very good thing to try for the patients that are potentially affected with struvites. Unfortunately, not a great possibility in cats. And surgical treatment for nephroliths, done fairly uncommonly, either incised into the kidney or into the renal pelvis. Keeping in mind that this is done, one of the reasons it's done uncommonly is because we can compromise the glomerular filtration rate and the renal function. So one report has shown that GFR will decrease by about 50% in the short term after surgery, but then some of that renal function over the long term will be regained. The other reason that surgery is not often done is because some of, or many of these cases can be managed medically with supportive care or just with monitoring because they are fairly asymptomatic. Any questions so far about the nephrolith treatment before we get to the ureterolith? Okay. So one of the reasons that we wanted to talk about ureteroliths today is because we're seeing more and more cases, especially cats with ureteroliths, and getting a lot more phone calls about cats and sometimes dogs with ureteroliths. And so I think it is more of, I don't know if it's becoming more common or just more recognized over the past few years. So the treatment options for ureteroliths that fall in the internal medicine world, the things that I'll go over, would be options to try to promote passage of those ureteroliths into the bladder. Michelle Oblak will talk a little bit about the surgical options around these cases. And then keeping in mind that because most of the cats that we see with ureteroliths are going to have calcium-based ureteroliths, then we're not going to go into medical dissolution because it's very unlikely to achieve. Most people will consider a cat or a dog with a ureterolith to be a medical candidate, at least initially, if there's minimal signs of renal damage, so potentially minimal azotemia. In some cases, if there's no infection, because some people will think that that ureterolith could be a nidus of infection. However, there are some concerns about going to surgery with an active infection. If the ureter on ultrasound is not progressively dilating, indicating that more and more obstruction is occurring, that could be a good condition for a cat or a dog being a medical candidate. And then as well, if there's not a lot of renal pain or pain along the abdomen that could be attributed to the ureterolith, that would also be a good candidate for medical therapy. One of the reasons that we try to promote ureterolith passage before sending these cases to surgery is because the feline ureter and the canine ureter is very small. So unlike in people where the ureter is larger and there's a shorter distance to the bladder, potentially medical management is going to promote the passage of that ureterolith a little bit easier. We're dealing with about a 0.4 millimeter diameter ureter in a cat. And so there's not a lot of room in there. So once a fleck of a stone appears, it can be challenging to promote the passage of that ureterolith into the bladder. Some of the things that we try to do would be aggressive diuresis, also weighing the cardiac status of the cat at the same time to make sure we don't fluid overload these cases. And one of the ways that we can monitor these cats to ensure that we're not getting into a fluid overload situation, either from their kidneys or from their heart, would be to monitor their weight, their hydration, and their urine production. And then there are a few drugs that we can try to look at to help us increase passage of that ureterolith as well, which I'll get into in another slide. Ideally, if that ureterolith will pass into the bladder, it's likely going to be voided out because it is so small. So likely in most patients, they'll be able to void it out. Cystotomy could also be an option in cases where the cystic calculi become persistent or become problematic, but that's a less likely consequence because of the small size of these ureteroliths. Usually, because we're balancing wanting these cases to try medical management for a little while, but also understanding that the longer the ureterolith sits in the ureter and causes renal obstruction, we're getting into a situation where we can have more and more renal damage occur day by day. So optimal time for trying medical management currently is unknown. General consensus, though, would be to try it for maybe 2 or 3 days, provided that you don't have signs of progressive ureteral dilation and worsening clinical status of these patients. Aren't great, we don't have great drugs to help propel stones down ureters. There's not a great ureteral motility drug or anything like that. But there are a few pharmacologic options that have been studied very briefly or very intermittently in veterinary medicine. And a lot of these medications are also borrowed from the human literature as well. Alpha antagonists, alpha-2 antagonists like prazosin, phenoxybenzamine, these can be used to help relax ureteral muscle. Amitriptyline or other tricyclic antidepressants have also been reported, at least in human medicine, to help relax ureters and decrease ureteral pain. So these are medications that we can often put these cats and dogs on while we're diuresing them as well, and cross our fingers and hope that these ureteroliths pass. To help increase the GFR and help increase the fluid movement through the kidney, through the ureter, into the bladder, furosemide, either bolus or CRI, can sometimes be used as well, balancing still that we need to keep these patients hydrated. One of the drugs that's often used in a lot of hospitals, and OVC is definitely included in this, are H2 receptor antagonists like famotidine. These are actually reported in humans to cause ureteral spasm. So how clinically relevant that is, we're not really sure, but we often will try to avoid famotidine or other H2 blockers in cases with ureteroliths. We know that, at least from humans reporting pain associated with passage of ureteral stones and other stones, and seeing our patients in these states as well, that this condition can be quite painful. And so we're in the position where we can try to provide some analgesics as well. One study in dogs showed that morphine can actually induce some ureteral spasm. Again, not sure how clinically relevant that is, and there's not a lot of morphine used in practice. No one knows about the other opioids and how good or bad they might be in terms of the ureters, but often it's indicated to try an opioid like a buprenorphine or another medication to help with pain relief for these patients. Because of the potential for kidney damage in these patients, NSAIDs are not typically prescribed for pain relief. So as far as how good we are with promoting ureterolith passage, no one really knows because there's very few studies reporting the success rates of passing these ureteroliths. There's one study from several years ago that looked at many cats that either went to surgery or were medically managed for ureteroliths. And 52 of those cats were only medically managed in that retrospective study. And medical management for this study included IV fluids and diuretics. So we're not getting into the phenoxybenzamine or the amitriptyline in these cases. 7 of the cats were considered to be successful. So 7 of 52 cats were considered to have success, meaning their creatinine decreased and remained decreased compared to their admitting value after IV fluid diuresis and diuretic therapy. And the treatment times for these cats is really variable. It ranged from 2 days to maybe a week or 2 or beyond. 16 of the cases out of the 52 had a stable creatinine value after they were diuresed, but clinically they were felt to be stable. They were considered to have a good quality of life, and they were considered to do well in hospital and beyond a 1-month follow-up period after discharge. 17 of the cases were either died or were euthanized within a month of therapy, and then another 12 were lost to follow-up, which might some of those cases might fall into any of those groups. What the take-home is, and these do add up to 52, what the take-home message here, though, is that 7 responded really well, 16, might have responded. So we're not looking at the vast majority of these patients responding to medical management, but it's still, because we're dealing with a very big surgical procedure, recommendations for big surgical procedures or euthanasia or poor quality of life, it's certainly worth a try to medically manage these cases, at least for a few days, provided that the animal is stable, in order to see if we can try to promote ureterolith passage. Interesting, of the 2 groups that were either responders or stable cases, 14 of them had radiographs that were tracking their ureterolith while they were in the hospital, and 9 of those 14 showed the passage of the ureterolith within several days, a several-day period while they were in hospital. So that was promising, and we can track those ureters in cases that are responding to medical management. Another thing that we can track is their creatinine value too. Some of the other considerations for treating these patients would be that they often have chronic kidney disease either during their initial kind of diagnosis where they have some kidney damage, or persisting even after either surgery or medical management is successful in resolving their ureterolith. And so we do recommend following these guys and monitoring them as a normal CKD patient, and treating them, whether that's with fatty acids or diet therapy. If ACE inhibitors or other medications are recommended, then pursuing those typical therapies for chronic kidney disease, cats and dogs. As far as other treatment modalities or other treatment options that sometimes appear in the literature, every now and then for complete ureterolith or nephrolith obstructions, nephrostomy tubes are placed as a temporary measure to divert urine from the kidney to the outside of the cat or dog while awaiting other types of interventions or therapies. And dialysis has been reported as well to make these cases, when they're very azotemic from obstruction, to make them better candidates for surgery. If we do fail medical management, then this is a time where we can look at either surgical or interventional therapies, and this is something that Dr. Michelle Oblak is going to talk a little bit more about. Before that happens, any questions about medical management for these cases? We have nutrition coming up after the surgery stuff, but any questions about medically managing? Anyone seeing these cases in their hospitals? Some, yeah. We're getting more and more phone calls about these cases as well. Okay, all right. I'm gonna wire you up, miss. Merci.
Hello, everyone. Thank you so much for coming. I'm not going to spend too much time because I don't really think that the specifics of surgical technique and such are really that relevant for you guys at this point. Unfortunately, these procedures are going to require sort of more advanced fluoroscopy and things like that. So you're probably not going to want to be jumping into them in practice. So I just wanted to talk a little bit more about the logistics of what it means when we're talking about putting in subs and stents. We are, as Shauna said, we're getting a lot of phone calls pretty regularly. People get a cat presenting, the cat's in acute renal failure or has evidence of renal failure. And the question is, should we be sending this cat for subs or stents? And I think one of the challenges is that it's this determination of, just because we see a stone on imaging, does that mean the cat's truly obstructed, or is the cat actually in renal failure for another reason? So I think for years we've been seeing these incidental stones, and now that we know we have options, there tends to be more of an inclination to jump to the fact that we need to be aggressively treating for these stones. But truly, these procedures are considered for treatment of obstruction. So we're not going to be just placing a stent or a sub in a cat just for the purposes of we see them and preemptively and things like that. Because as you'll see, there's a pretty extensive amount of management involved in sort of dealing with these cases. So we really don't want to be just kind of jumping into doing these. Ureteral surgery in general is something as surgeons we really try and avoid. You know, if there's complete obstruction occasionally from a tumor or sometimes with evidence of a stone, things like that, it may need to occur if there's a stricture. But one of the real challenges that we have with doing ureteral surgery is, as you saw, as was mentioned earlier, a normal cat ureter is about 0.4 millimeters. Well, I'm not really trained in microvascular surgery, and when we're getting into the 0.4 millimeter range, we're talking about using like 9/0 suture. So maybe we could call in the ophthalmologist to help us, but in general, not really something that many of us are going to be that easily able to deal with. You're talking about operating microscopes and things like that. And so in a normal ureter, we really don't like to have to be cutting that ureter and doing any sort of surgical procedure. Also, if you think about a 9/0 or a 0.4 millimeter lumen, we're talking about a very, very narrow area, and so the risk of stricture is extremely high. And so that's actually more why we prefer not to be doing surgery in these. And even in ureters that are dilated, there's still a concern about stricture, and that's why we quite often we'll try and avoid ureteral surgery as much as possible. One of the other complications, it can be a uroabdomen, and again, has to do with the fact that how far do you space your sutures apart? How many sutures do you put in? How do you avoid putting too much suture material so that you're causing a narrowing of your already small lumen? So overall, ureteral surgery, occasionally we have to do it, but we really try not to. When we get into stenting, essentially a ureteral stent is a double pigtail, as you can see here. So there's one end of this that goes into the bladder and one end that goes into the kidney. And essentially it comes so that it can be straightened out. So we place a guide wire down from the kidney into the bladder, or we place it retrograde from the bladder into the kidney. And between those two structures, we place the guide wire and then we feed this stent over top of the guide wire. When we remove the guide wire, these ends right here will curl up within the renal pelvis and within the bladder through the ureteral papilla. Again, with the goal of it not moving around. So the goal is hopefully with these little pigtails, they will hold it in place. One of the challenges associated with these procedures is, again, if we're talking about a 0.4 millimeter ureter, there's not a lot of stents. The stents don't get that small. You know, the smallest stent, I think now they're making a 4 French cat stent, but they're not as small. And so we are ultimately relying on our ureters to be dilated in order to be able to place stents. In dogs, it's a little bit easier, a little bit bigger, a little bit easier to see. Often they seem to get obstructed more distally than it seems, at least in my experience in cats. And so in those cases, sometimes we have a little bit more success in placing stents, but in general, cats can be really challenging to place stents. Some people place them percutaneously. I personally am not at the point where I can do that. You know, I think we have fantastic radiologists, and I don't know if Dr. Singh has that experience, but certainly I'm lucky if I can get a stent in a cat period, and I have to say it's only happened once. So, you know, generally really difficult to do. And we don't, at this point, I don't actually attempt it in a lot of cats if they don't have enough ureteral dilation, because I think these cats are often sick cats who are quite azytemic. They're not the best anesthesia candidates. So in my mind, we're kind of trying to do what we can to address their problem as quickly as possible and have them wake up. And, you know, in the past, we were trying a lot longer and a lot more aggressively to place stents, and it's very, very difficult in these tiny ureters. They do require for us a laparotomy and then fluoroscopy guidance. So we do essentially do a pyelogram, try and assess where the renal pelvis is, try and place that guide wire through. We're going to pass the guide wire down. I'm sorry, I had a video, but I couldn't get it to work. And then you pass the guide wire down, then you're going to feed your catheter over top. And then as you remove that guide wire, you get the curling of the pigtails that sits within the ureter. That you do need to leave a fair amount of redundancy in those catheters, because the ureter itself does have quite a bit of redundancy. And so if you make them too short, then they can actually cause either a lot of irritation, they can migrate more easily. But at the same time, you don't want to make it too long, because if you make it too long, then you have a ton of material sitting within the bladder that's going to irritate the bladder as well. It does cause dilation of the ureter. So as soon as you have a foreign material in there, you're going to have dilation of the ureter. There aren't actual holes within the catheter itself. The ureter is actually going to dilate, and then the stone may pass beyond. But at least with the ureteral dilation, the idea is it gives a conduit for the urine to pass through. So the whole point of this stent is that you're allowing urine to pass naturally from kidney into bladder without having to do ureteral surgery. Occasionally, in cases where we have to do ureteral surgery, so for a stricture, if we can't pass it and we think we have to do that, or more in dogs, but if we have a very large stone and so we feel that it's appropriate to do ureteral surgery, but we're concerned about healing, we're concerned about stricture and things like that, then sometimes we'll place a stent to allow that to kind of provide us a little bit of time for healing. These stents can be removed or they can be replaced as needed. And so sometimes if the obstruction is resolved, then if we feel that the stent is giving the animal trouble, if they have any evidence of chronic pyelonephritis or things like that, then sometimes we will remove them. The nice thing is that the pigtail is actually fairly soft, and so we can remove them by just pulling them. We can pass the guide wire and pull them that way. So we don't have to actually do anything with the kidney. In theory, we probably could do it with the scope, but in a cat, we're not really going to be at that point necessarily, depending on the size. So even just a small cystotomy incision to be pulling it, or with the scope in a dog. Sometimes the stones may pass, requiring a later cystotomy, and Dr. Singh's going to talk a little bit about the options that we have for minimally invasive, and so this is a really great option to avoid having to do a second large surgical procedure. We now have done a laparotomy, but if these stones pass later, as Dr. Blois said, we don't often have to do that. So we're showing you some of the extreme examples where you see these nice big giant stones on the screen, but there's going to be lots of situations where these are very, very tiny little stones, but it doesn't take much for 0.4 millimeters to become obstructed. One of the challenges, as I mentioned, in cats is for some reason they seem to actually obstruct a lot more proximally. And so the challenge with that is that there's not a lot of ureteral dilation because it's all proximal. So distally, the ureter doesn't dilate. And that's where placing the stent can be more of a challenge, because yes, we have a little bit of dilation proximally, which is great, allows us to pass our guide wire, gives us a little more access. But even just passing the stent, you get a little bit of spasm of your ureter, and sometimes you're done. You can't continue to pass that down. So that can be a little bit frustrating. There is an increased risk of infection. You now have an implant in there, so you're concerned about if your animal has a chronic UTI, creating biofilm, and what options we have in terms of antibiotic therapies. The stents can migrate, so they can migrate down out through the bladder, or they can migrate proximally if they're not long enough back up into the kidney. Sometimes that's an issue, sometimes not, depending on where your obstruction is and if the stent itself actually causes any obstruction. And then in some animals, that little pigtail within the bladder can cause some irritation and hematuria. So that can be very benign, but it can be difficult to assess, is it related to infection? If we're not doing regular cultures, if you suddenly see clinical signs with the owners mentioning hematuria, or some of these guys can become very strangiuric or plaquiuric because they feel that in there and they're straining constantly because of that. Excuse me. So generally in cats, if we can, ideally a stent versus a sub, the main benefit is that the stent hopefully can be removed if needed, if needs to be changed, all of those things. You are still allowing a natural process, so your ureter in theory should still be completely functional with this stent in place, and so you're not causing sort of long-term diversion of urine. And so ideally, if we can place them, that would be sort of the first line choice, but to be honest, and I don't know if Dr. Singh's experience is different, but I don't find that there's many cases where we do find that the cats are the best candidates for stent placement. And so in general, we're actually probably more frequently placing the subs, or the subcutaneous ureteral bypass device. And so you've probably started to hear about these now. They're a few years old. They were created by, well, it's a human device that was modified to be used in cats, created by the interventional group at AMC. And essentially, it's a nephrostomy tube. So the same pigtail nephrostomy tube are very similar that you would use if you were decompressing a kidney on an emergent basis. And then it's attached. So nephrostomy tube here, and this actually is it's on a cord. So it's on a string so that you can actually retract that, and then it creates a nice little curl. This part is attached to your kidney, and that's actually just attached with glue. This part here, and this is a very short version, obviously this wouldn't fit in a normal animal, but just as a good demonstration, is passed to this port. And this port is actually a port that's used for several different things. So vascular access ports, it's used for ureteral cuffs if you're doing anything for those things as well. And essentially, that port sits subcutaneously. So you have your nephrostomy tube within your abdomen that comes up and out through your body wall. Your port is attached to your apaxial muscle, sitting subcutaneously, so you can palpate it under the skin. Then the other end, so this end here, is attached again to this port. And then this is, again, within the abdomen through the body wall and into the bladder. And this is sutured and glued into the bladder. So you have your cystostomy and your nephrostomy tube, and they're joined together. These ports are really nice, but you do have to be a bit careful with them. So we use a non-coring, what's called a Huber needle, to do any sort of access to them. And the reason for that is that it's rubber, and so if you're constantly poking that rubber with a regular needle, you're gonna wear it out. And that is unfortunate, because then you have to go back and replace that port, and it's gonna leak and things like that. So with these non-coring Huber needles, they have a little angle on them, and so rather than going directly in like a normal needle, they come in at a bit of an angle, so they don't core the rubber. So they can be used over and over again. And so in theory, they shouldn't have a lifespan. They should be able to be poked fairly frequently without any issue. There aren't any valves or anything in those, but there generally isn't issue with reflux, at least in our experience. Everything flows kind of in the normal direction. You can feel that button under the skin, so that's always something to have a discussion with owners about. I've played around with where to put it. Excuse me. And I don't know that there's a great, there's one place that's easier than others, and we want to be able to access it, so we want to place it in an area that isn't going to be too covered in sub-Q fat, but also in an area that's fairly comfortable for the cat. So I've never really found that they have issues with wanting to lie down, or they don't seem to be uncomfortable for them. And the ultimate goal of this device is to completely bypass the ureter. So this is essentially an artificial ureter. We've completely bypassed it. It no longer has any need to be functional. That doesn't mean that in some cats or animals where they become partially obstructed, or they're partially obstructed and the obstruction relieves itself, that doesn't mean that they're not necessarily going to use their normal ureter. So we don't really know. We don't do enough kind of evaluation of exactly where urine is flowing with contrast to know for sure. But I suspect some of these animals actually probably relieve their obstruction on their own, and then actually are passing urine in both directions, or potentially even just through their normal ureter. But the idea behind this is that it's an opportunity to completely bypass the need for a ureter. So from a surgery perspective, this is a lot more straightforward. Generally, you need about a centimeter of pilectasia in order to be able to easily pass that nephrostomy tube, because as you saw, it has a curl on it, and so it can be a bit difficult to pass that into the renal pelvis if you don't have at least some degree of dilation. And if you don't have any dilation, you probably this is probably not an appropriate procedure. So generally, if you have an obstruction, you should have pilectasia. So if you don't see anything, either you've caught it really, really early, which is possible, but in general, we at least have some degree of dilation. It does require laparotomy. You're going to be putting the one port into the kidney. It's just a single stab incision with the device, so it's pretty straightforward. Everything's kind of done off of the device, and then the nephrostomy is glued on. In theory, that can leak around that. I haven't personally had any issues with them leaking around the sites. If anything, where I worry about leaking would be the bladder side of things, just because the bladder does change size so much, and some of them are quite thin. But generally, placing it is pretty straightforward. We'll keep these guys from a procedure perspective in hospital for 24 hours. Sometimes we'll put abdominal drains in them just to monitor in case there is evidence of a uroabdomen. But typically, they tolerate them extremely well. I think the biggest, not necessarily drawback, but the most important thing kind of in terms of management and discussions with owners is at this point, the follow-up management for the subs is pretty involved. And so we're going based on the advice of what's done at AMC, because they're the ones who kind of pioneered the device and have done the most extensive work in terms of monitoring and recommendations. Yes? What's the point of the port? Yeah, so the port, it allows us to sample. So you can sample and you can get culture and everything, so you don't have to ever do cystos, because you don't want to worry about poking by accident. And then it also allows us to flush, so that if you do have an obstruction, so we don't know for sure, these can get clotted with blood clots, or potentially even stones themselves. So it gives you a spot to flush. And so the big thing with these is at this point, the recommendation is monitoring essentially every 3 months for the cat's lifetime. At some point, maybe it could back off to more like 6 months, but ultimately the recommendation is to see these cats fairly regularly. We're seeing them, we're doing abdominal ultrasounds to assess their urinary tract. We're doing blood work to assess what their degree of azotemia and how they're doing that way. And then we're also aspirating, taking samples, doing urine cultures because we're worried about the potential for them having more chronic UTIs and issues with pyelonephritis. And then we're also flushing the ports at that point to see that they're patent. So you can actually see if you flush the port, you can actually see bubbles enter into the kidney and into the bladder when you flush, and so you can confirm that it is patent. And we do a fair number of these bilaterally because a lot of animals present bilaterally obstructed, and that's why we're seeing them clinically for issues. And so in those cases, we can actually use a single port, and it's possible to see flushing from all in all sites. So it's quite helpful in that way. And so the big thing is pretty extensive monitoring, and then long-term data on these. It's probably been 5 or 6 years, I guess, I think now that it's been used, maybe up to 10 at AMC, but we don't have long term. So we're talking about potentially if a cat was otherwise completely normal, had normal renal function, we're planning on it living a long time. We don't know how these devices are going to hold up for 10, 15 years. And so I think that's just something we always discuss with the owners, is the understanding of, are we going to have to replace components at a certain point? Is there a risk that they could become, that the tubing could become encrusted? Could the tubing rupture? So, this is silicone tubing, they're used for long term, but at the same time, could there be a tear or something in the device, leakage around the ports, anything like that? All of those things are possible. And so that's one of the challenges that we sort of see. So you can see in this radiograph here, this is just a lateral radiograph of a cat, a little bit of lung here, so cranial to the left of my screen. And this is the tube, and it's a little bit end on, so it's hard to see that nice curl, but this is the tube sitting within the renal pelvis. There's a little cuff, as I said, that sits along here. Then the device sits fairly loosely within the abdomen, so we like to leave a fair amount of extra tubing so that they can move around. We're not worried about them putting any tension. The device is then exiting through the body wall. It's attached to the body wall here, and then it's re-entering the abdomen there, and then the second cuff that then attaches onto the bladder. And those sit in there pretty comfortably. My experience hasn't been that the cats seem too bothered by the actual devices. One of the challenges is in some of the really fat cats, it can actually be really hard to find the port. And so we always do these added because we would hate to poke by accident, to actually poke some of this tubing when we're looking for the port. So we want to make sure we know exactly where the port is. We want to go right in the center of the port. We're again using the Huber non-coring needles when we're doing it. And then we're using ultrasound guidance to assess what degree of changes are occurring when we're flushing, just to see for bubbles and things like that. Great. I think this is a meet. Perfect. Great, so I'm going to hand it off to Dr. Singh. Was there any questions at all? Yes. Just to clarify with the stent, did you still take out the urolith? So we don't. So essentially the catheter is passed beyond. So the question was, do we still take out the ureterolith if we're placing a stent? And we don't. So we pass the guide wire and then pass the stent over the guide wire. And so the goal is that we don't remove those ureteroliths because that would require incising the ureter. And so they may pass on their own or they may sit there long term, but it allows the urine to be able to bypass that area. It hasn't seemed to be an issue. It's a great question. I think the thing is the ureter does have some dynamic component in terms of its ability to dilate. And so having that stent in there seems to encourage that little bit of irritation, seems to encourage some dilation. And I haven't personally had that experience where they have issues from that perspective, but I can't say that I've done many in cats. Great, thank you very much. If you think of any other questions, we can certainly chat at the end.
Thank you.
Right, good question. So a lot of it
actually has to do probably with their pre-op condition. So in terms of cost, cats that are very, very stable coming in, maybe early obstructions, aren't really sick from their azotemia. If we're looking at stents, we're probably looking in the $3,000 to $5,000 range if they're pretty straightforward. Sometimes a little bit less. With subs, we're quoting most people more in the $5,000 to $7,000 or $6,000 to $8,000 range. A lot of that has to do with how sick these guys usually are, so they're not usually pretty straightforward patients. But they do typically stay with us for 3 to 4 days after surgery. And then the owners have to be, I think the most important thing is really making sure they understand that this is a lifelong commitment for follow-up. It's not just an immediate, we deal with it, they're done, they go home and they're fine. There really is a fair amount of kind of long-term care and costs.
Thank you.
So the rechecks, somewhere in the $300 to $500 range by the time we do urine cultures and flushing and then ultrasounds and the blood work.
Okay, well, thank you very much to Dr. Blois and the medicine service for having myself and Dr. Oblak chat to you guys in this session. And these are appreciation rounds after all, so thanks so much to you guys for coming out this evening, braving the cold, and most importantly, thanks so much for sending us all your cases. We really appreciate that, and so hopefully we can continue doing these rounds throughout the year, and we hope that you enjoy them. So we're just, oh, the other thing is that Dr. Alexa Brasanis is in the back. She wasn't here when we were doing the introductions. She's got some very exciting slides to talk to us about very shortly. So I'm just moving down the urinary tract here, the bladder, urethra, obviously cysto, ureterolith. I think these are something that you guys probably face on a weekly basis. And I just have a few slides, so I just had a few things that I wanted to cover with you, and then maybe show you just some newer treatments that we're doing for removing cystoliths. So, you know, classic radiograph here. There's several radiopaque stones in the bladder, and then these dreaded, oh, Jackie. These dreaded, oh, I'm not, these dreaded urethroliths that, you know, always cause us a pain to us. So I think that urethral surgery, kind of like ureteral surgery, should be avoided at all costs. And I think in most cases, I don't want to say in 100% of cases, but in most cases, I think that with persistence and, you know, following some basic rules, we can get most of those stones back from the urethra into the bladder, and we can do a much easier procedure like a cystotomy. I think you guys are all probably very comfortable doing a cystotomy versus urethral surgery. I know for us, we find it's challenging. It's bloody, it can result in a higher complication rate. So we'll work very hard to try to get all of those stones back from the urethra into the bladder. So a few tricks, and I think, you know, probably many of you guys are doing this already, but I just wanted to go over a few things. One basic rule that we always follow when we're doing retrohydropulsion, which is to get the stones back into the bladder. These dogs have to be under general anesthesia. It's very, very challenging to get the stones back from the urethra in an awake or just sedated, even heavily sedated dog, because I feel that these dogs are painful, they're spasming. I think they need to be under GA and relaxed. So I think that's huge. An assistant is very helpful. I'll get into my animation that I must credit Dr. Judy Brown, who is she's a criticalist at the BEC in Toronto, and she's very skilled in her artwork, and I've used her for several diagrams. And this is very helpful. This was very helpful to me in explaining this. I use this for the students all the time too. So we've got our, this better work, Jackie. We've got our, oh darn. So we've got our urethroliths. You can see here the dog's under GA in lateral recumbency. Now, I think a catheter, we just use a feeding tube initially. That works just fine. I think the secret is when you're selecting a size of syringe to flush these back, the tendency is to use a big, so 60 cc, 35 cc syringe to try to get the most amount of saline so that you don't have to replenish your syringe after you've attempted a flush. That is fine. However, I would recommend using something smaller because you can get much more pressure on the end of that syringe into your feeding tube or catheter, whatever you're using. Okay, so that's one thing. The next step is an assistant, whether it's yourself or that's doing this and your assistant is flushing. The assistant should have their finger per rectum and occluding the urethra. Now you can easily feel the urethra per rectum, as you guys all know, so that should be occluded. Now, such as in this diagram. So the occlusion should be done at the same time that an initial flush is being performed. And then in concert with the person who's doing the flushing, when you release, these stones will flow through into the bladder. Now, it may not be as easy or as quick as these 3 steps. It may take more, and sometimes we've spent an hour plus in radiology or in the prep room trying to get all these stones back, but you get the premise. So in summary, dog under general anesthesia, relax, muscle relaxants, an assistant per rectum with their finger, occluding the urethra. Flushing is happening. Now what happens is that the urethra then dilates distal to where the occlusion is. And then when the assistant releases that finger, they'll flush forward. They might not go, again, they might not go right into the bladder. They'll progressively move their way up. But this works for us. I don't know what you think, Michelle. Like, I would never say 100, never say 100, but you know, in the vast majority of times, and sometimes we do work for a long time because we want to do everything we can to avoid getting into the urethra.
So
all right.
If you can do an epidural too.
Yeah.
That, I don't know, for me, I find a lot of times,
Thanks.
even under general anesthesia, they're still, so it's a great thing to practice it. You know, I think they're very straightforward to do practice.
Any questions about that? Okay, so we've got our stones all into the bladder. We're all set to do a cystotomy. So, you know, one thing that our service has done a lot more of in the last 3-4 years is to do minimally invasive surgery consisting of laparoscopy, which is minimally invasive surgery of the abdomen. And so there's an assisted technique that we've kind of adapted over the last few years to do cystotomy. And so just have some pictures of that technique. And so a couple things compared to doing a traditional open cystotomy. And so here we have the dog lying on their back. The head is over to your left, and then back end is to the right. The prepuce is draped out of the field here. Now that one thing I always teach the students to have the prepuce in the field for a male dog when doing a cystotomy. And the reason is because maybe I'm a little bit anal, but I want to have control of the ability to flush the lower urinary tract myself. I don't want to ask you know, a non-sterile assistant to get underneath the drapes for me and only have one time, or the potential for one time to do that. So I will drape the prepuce within the field for an traditional open cystotomy. So that may be one difference. So what we've done then is we've placed a portal. It's one of these steel cannulas into the abdomen, and what we've done, a second portal is here, and that was just placed peripreputial. And what we've done then is grabbed the urinary bladder, which is right here, and so we've extended this portal incision, which was about this long, and we've doubled that and then pulled the urinary bladder out. Not the whole bladder, just the tip of the bladder. And then what we're going to do then is essentially create a purse string with the urinary bladder to the skin. And so that's what it looks like. So we've got this little, you know, maybe about 1 centimeter, 2 centimeter portion of the urinary bladder sutured to the skin. And then what we do is we'll take that steel cannula that was into the abdomen and actually insert it into the urinary bladder. I have a video to show of that. Now, one thing, I'm just going to pause this. Mr. Kevin Hogg is in the back. He's videotaping this event this evening. He videotapes all these events. He has a tireless job because he spends a lot of time with me editing these videos. So thanks, Kevin. Appreciate that. So here's a view of the urinary bladder. We've pulled that out. We've sutured it. And now we've got our cannula and camera in the urinary bladder. And so there's a view of all of these stones. And I think the view that you get using laparoscopy, which is now essentially a cystoscope, so the scope is now in the urinary bladder, is impeccable. 1,000 times better than what we get with an open cystotomy. And so essentially what we're doing is we've got this cannula and we've pulled the camera back up the sheath, and we turn suction on, and then we'll essentially just suck up all of these stones. And so I think probably some of the advantages with this technique is we can see a lot of the really small stones that we might not see. Some of these bigger stones for sure we would see obviously with an open cystotomy, but we can easily snag them with suction, and it's actually a very efficient technique. I think obviously some of the disadvantages of this technique is the equipment that we need. Kim is in the back row. She's one of our surgery techs. She never complains, and I always ask for this equipment to come out. So thanks, Kim. But that's probably one of the disadvantages. I think anytime we do minimally invasive surgery, I think case selection is absolutely critical. And so some dogs that have, a huge amount of stones or a high stone burden, we don't take those to do a lap-assisted technique. So sometimes if the stones that are too big to fit up the cannula that's in the bladder, we can slide a hemostat down and grab them just one by one. Obviously only if there's a handful, because we're not going to spend all day plucking out 15 stones that way. I think we'll see in a second, another huge advantage with this technique is the ability for us to see down the urethra. And so once we feel that we've cleared out all the stones, we deflate the Foley catheter that we've left in there that's constantly flushing out or constantly providing saline into their bladder, and it's slowly withdrawn. Usually Kim's doing this for us. Thanks again. I know that job must not be too pleasant, Kim. So I'm very grateful. And so now the catheter is being withdrawn and fluids are still flowing. So we can be absolutely sure there's no stones in the neck or proximal distal urethra even. And then we can take one final look through here. So that's probably the highlight of the video. And we can have a good look through and make sure there's nothing else left. We obviously, just like if we were doing an open cystotomy, we'd definitely take every single one of these patients back to radiology after to make sure there's no stones that are there. And then there's our closure. So we've actually done a little bit of research on our first about 50 cases, and some of the highlights from that research. Time, this procedure took a little bit longer to do, but we do feel the advantages of that definitely outweigh the cons of being in surgery a little bit longer. And usually these are healthy patients. If they're systemically ill, they're probably not having a minimally invasive approach done. I think the other thing that we always have questions about is the cost. And the minimally invasive procedure is about $200 more. And so the surgical fees are, $200 more. But overall, we found in our study that there's no difference in cost between open or the MIS approach. And probably is because a lot of these dogs are leaving the next morning instead of maybe having to stay a little bit longer to diurese them after surgery. I think one of the big things too, we didn't find a statistical difference, but very few of these dogs have hematuria after surgery compared to dogs that have an open cystotomy. So that's another up-and-coming technique. And if you have any questions, happy to take those. Yep. Well, I don't want that.
So your tool that you got, your laparoscopic incision for that, is going into the bladder intra-abdominally?
Yes. So what we've done here is, so this cannula was initially, or is in the abdomen, and our camera initially went through here to look around the abdomen. It's amazing. A lot of these dogs will actually find some other concurrent lesions. Tons of these dogs will do liver biopsies on just because of concerns that we may see. Doesn't take us long. We don't have the camera in the abdomen for too long. And then we'll find the urinary bladder with a cannula that was in this location just beside the prepuce. And then we'll put an instrument in this location, grab the bladder out, and then suture the bladder to the skin. So then in most cases, our incision into the bladder is about 5 or 6 millimeters, just enough to fit the cannula in.
So the laparoscopic incision, that's just to look at the abdomen, that's not nothing to do with the
Exactly.
Okay.
Yep. Okay, thank you. Your pointer doesn't work, Jackie.
It's fading. Maybe the battery's low.
I don't know what to tell you. Thanks.
Thank you. All right, can everybody hear me okay? Perfect. You all came for the nutrition part, right? We fed you cookies and lasagna and lots of carbs, and now you're all postprandial and ready to listen to me talk. So I'm here from the nutrition service, and we're going to talk about nutrition support plans. And the reason we call them nutrition support plans is because the World Small Animal Veterinary Association and also AHA have come up with some nutrition guidelines. How many of you have heard of the nutrition guidelines? How many of you are implementing them in your practice? Even better, there's cookies up here, and I might give you one if you're implementing them in your practice, because I don't give my patients cookies, but I can give you guys cookies. So most of my patients are on diet. So with respect to the nutrition guidelines, instead of just calling it a plain old diet plan, or we're going to give you a diet, it's really a nutrition support plan, because you are using nutrition to support either your medical or surgical interventions for that particular case. So yes, nutrition can play a very big role, especially with urolithiasis cases. And obviously one of the most important things here is moisture. So there's one thing you have to harp on with owners. It is moisture, moisture, moisture. And I'm not condoning dogs drinking out of the toilet bowl, but this is just too adorable of a water fountain not to include in a presentation. But with respect to water, people will often say to me, well, how do I know if I'm actually getting enough water into my patient? Well, one of the best ways to assess that is to use a urine sample, and we want to look at the urine specific gravity. So for dogs, our ideal target is to get the urine specific gravity under 1020. And it's pretty easy with dogs, well, at least most dogs, to try to get a urine sample in the morning. I know my neighbors over in student family housing think I'm absolutely insane, because I'll be out there with a disposable glove on and a little bowl walking around after my dog to get her urine sample in the morning. And then I've caught the pee, and then I can use a refractometer to assess the specific gravity. But it's great because if it's less than 1020, we have an idea that we're really diluting things. With cats, it can be a bit more difficult to get a first morning urine, because cats are not always the most agreeable to our plans. But if it's possible for them to get a urine sample, and I've recently started using a really cool litter product called Kit for Cat, where it actually looks like gravel, but it's really neat because if you put the urine or a sample of water on top of it, it actually pools on top. So instead of using something like a nose orb litter where most cats will get really upset and not necessarily pee in there, there's some really great options coming for them to be able to collect a urine sample at home, and then we can see whether or not they're within the target range. So we'd aim for about 1030 or less in cats, and if you can get an owner to get their cat down to 1030, big pat on the back, because that's a great job well done for that desert dwelling creature to have a specific gravity less than 1020. So definitely it's the most important thing for all cases. Now, lots of people will say to me, well, what if we've got a patient that's not a good water drinker? And I would definitely suggest encouraging them to drink as much water as you can. So maybe it's a matter of just putting multiple water bowls around the household. You might have noticed that some cats can be a little bit lazy. So you've got to remind them that they should be drinking water. So you want to have a water bowl where the cat sleeps or by the window where they spend most of their time. Cats can also be a little bit picky or particular about things. So maybe they don't like that their little whiskers touch the edge of that water bowl. So maybe it needs to be a little bit lower, a bit more shallow. Maybe they don't like the reflection of the stainless steel bowl. So maybe you need to avoid that. So we've had some owners have, 5, 6, 7, 8 different types of water bowls throughout the household. And it's amazing. Eventually the cat will develop a preference for one of those. I have one owner that was so desperate to get her cat to drink that she ended up, one of the bowls she used was fine china. And guess what? The cat liked that bowl best. So it was kind of funny, but I was like, whatever you got to do to get your cat to drink water. Definitely you can consider flavoring the water. With dogs, we might do something a little bit sweet, like a little bit of honey or a little bit of maple syrup, because they do have sweet taste receptors. Obviously, you're not going to do that for your diabetic patients. That would be a bit of a problem. But with cats, we might use something like clam juice or tuna juice. Now, we want to avoid the ones with lots of sodium or lots of extra flavoring. The problem with tuna juice is that usually after they've drained off a little bit of juice, then there's a whole bunch of tuna, and your owners will complain that they're having to have tuna salad sandwiches every day, so which isn't always that popular. So you might want to use something like clam juice, because you can actually just buy cans of just clam juice with no clams in it, so then they don't have to do anything with the clams. So that's something that you can do. In addition to the water bowls and flavoring it, we've also used ice cubes with little bits of flavoring. It's often a bit easier with dogs to use something like that, but why not try it? What do you have to lose? The other thing that we can do is have those running water fountains, or if you've got one of those cats that in particular really likes to drink when you've turned the faucet on, maybe there's a certain time of the day where you go and you turn the faucet on for a few minutes so your cat can have a drink, and then you know at least they've gotten some water into them. So lots of different tips and tricks. Obviously, the easiest way to get moisture into our pets is going to be to feed them a canned food. So anybody have any idea what percentage of moisture is in a canned food? Any idea? I hear whispers. You gotta say it louder so I could hear it. I'm sure you're probably right. It's about 70 to 80% moisture. And comparatively with a dry food, how much moisture would be in a dry food? Any idea? 10%, exactly. So if you are going to feed a pet a canned food over a dry food, you're getting 60 to 70% additional moisture right off the bat, which is a wonderful starting point. One of the other ways that will increase moisture intake is to use small frequent meals, because a lot of pets will drink a little bit of water after a meal. And so if they're going to drink, and if we feed them 2 meals a day, maybe they drink after both those meals, but if we feed them 3 or 4 small meals a day and they drink after each one of those meals, we might be able to increase their water intake even further. One of the other things that I like to do is to turn the canned food into a slurry. So are any of you doing this in your practice right now? And it can take some time. There are some animals that won't eat the canned food slurry right off the bat. But through perseverance, we've found that if you add it just like a teaspoon or even up to a tablespoon at a time, that you can gradually increase the amount of water that you're adding to that diet. And eventually you've basically got patients that are eating soup, but it's wonderful because they've got really, really dilute urine. And dilute urine is very important because if the urine's dilute, we don't have all those little components, those little constituents that are working together to form stones and crystals and then grow and flourish. So the more dilute we can make the urine, the better. The other thing that is really, really important from the standpoint of all these different stone cases is consistency. So we really want these patients to be eating a consistent diet. The diet type is going to depend on whether or not, first of all, if we know what type of stone it is. And if we do know what type of stone it is, great, we can come up with a more concrete plan. But maybe it's one of those cases where we just don't know if it's going to be a struvite or an oxalate case. And we've got some neat technology we'll talk about to try to address that. So I think that probably the hardest thing for these cases is to keep that consistent diet, which typically means that we want to avoid things like treats. And the way I explain it to the owners is you've just spent a bunch of money to have these diagnostics and potentially a procedure done. We're also going to be following up with your patient long term. And if you're feeding a consistent diet, but you're adding a whole bunch of different treats on top of it, you're really taking the technology that's in that diet and you're sort of just throwing it in the garbage, right? Because if you're adding a whole bunch of extra treats, which could have a lot of extra sodium, could have a lot of extra calcium, depending on what it is, we're really ruining that technology that's working for us in that diet. So I try to explain it that way. Now, some owners are going to be more on board than others with respect to keeping treats out of the diet. So one of the tricks that I've learned to use is to actually take the particular veterinary therapeutic diet they're on and make it into either a dry crumbled up cookies out of the dry food, or to actually cut up the canned food and make it into like a jerky style treat. So if they were to use one of those ninja blenders, I don't recommend using it for your own food after you've used it to crunch up a bunch of kibble, but you could crunch up a bunch of kibble, mix it with water, and then they could make little spoonfuls onto a baking sheet. Yes, their kitchen's gonna smell lovely after they bake dog or cat food, but at least they feel like they're giving their pet a treat. And that might really help with compliance if you can get them to do something like that. For a lot of owners, I find that it's just about them being involved. They really like the idea of making their pet something. They like the idea of giving them something that's not in the form of a kibble or not in the form of canned food. And so actually just changing the shape and texture of that food can really help them feel a lot better and can really improve compliance. When it comes to the canned foods, we'll try to get them to open the can. And you know that canned cranberry stuff that just comes out in the big log at Christmas time or holiday time? You remember how you slice it up? If you actually take the canned food and slice it up like that, and then you can quarter it, if you put it in the microwave for a few minutes, you can actually make it into almost like a jerky type treat, and then they can use it that way. The thing to remember is because we're re-cooking the pet food, it is going to destroy some of the really sensitive vitamins. The B vitamins are pretty sensitive, guys. So it's going to destroy some of those. So we want it to still be less than 10% of their diet, but it can really help improve compliance. And then, of course, from the standpoint of monitoring, surgery and medicine have both talked about monitoring, but monitoring from the standpoint of diet is also important to make sure that they're being compliant and they're feeding what you've recommended. So there's a couple of different things that we can consider when we need to talk about struvite cases in particular. Now I've got a couple of diets, a couple of charts here. The top one is referring to dissolution because obviously our struvite stones, we can try to dissolve those. And then also at the bottom, we've got prevention. And I've got what we like to call in the nutrition world our key nutritional factors or our KNFs. And that's some of our cool nutrition lingo. And the other thing that we've got on there is urinary pH. So this is the pH and the key nutritional factor approach. Not surprisingly, water, we want it to be increased. So we've got high water here. With respect to urine pH, if you're focusing on a dissolution diet in particular, the pH is going to go a little bit lower. There's going to be a bit more acidification happening there as opposed to more of a prevention diet. Now, this is one of the reasons that diets that make patients acidified can't be fed long term because we don't want that patient to be on an acidifying diet for a very long period of time. One of the things that could happen is it could actually predispose them to another type of stone, which would be calcium oxalate. And also, if a patient has any signs of kidney disease, which was talked about a little bit earlier in the medicine presentation, we definitely don't want to acidify those patients. We want to pay close attention to their acid-base balance. Also not surprising, when it comes to some of the key nutritional factors we've listed, we've got magnesium, phosphorus, and protein on there. So the way I teach this to the students is you just have to remember the other name for struvite, which is magnesium ammonium phosphate. And if you remember that other name, you'll be able to remember the key nutritional factors for struvite. So the phosphorus is obviously the nitrogen component that would make the ammonia. So we're not going to dwell on this a whole lot because there is a newer technology that I would like to talk about. And I'm sure some of you are familiar with Dorian Houston, who's pretty much a Urolith internal medicine guru in Canada. But I was lucky enough to be able to borrow this slide from her. And she really talked about when we've increased our knowledge and as time has gone on, we've really become much more advanced in the modalities that we use to actually treat stones. So we started out with just moisture, and then way back when ash was very important, magnesium was the next thing, and then we moved on to pH. But the thing that I really want to focus on here is relative supersaturation technology. And so how many of you are using diets right now that use the RSS technology in your practice? So quite a few. Excellent. So the biggest question I often get is, well, how can one diet work for two different stone types? And I think that becomes really confusing because when we talk about this approach with key nutritional factors and urinary pH, this is very specific for just struvite. And then there's another urinary pH that's very specific for calcium oxalate. But then you're telling me that there is this one diet that can actually work for multiple stone types. So the way it works is by focusing on much more than urinary pH. So it actually considers what we call the calculogenic ions. And that's just fancy for taking into consideration all the things that would come together to make a stone. So if you've got calcium oxalate, you've got to have an equal ratio of calcium and oxalate in the urine. They start to precipitate out, and then it forms a stone. So we want to pay attention to that. With struvite, we've got magnesium, ammonium, and phosphorus. So those things would come together to make a stone. So we take all that into consideration. We also focus on pH because it is important, but we're more focused on just maintaining a normal pH range for a healthy animal. So anywhere between, 5.5 to 7, and they're going to fluctuate throughout the day based on what they're eating and what they're drinking and those sorts of things. So I just really want to be within that normal range for a healthy patient. And then we're also going to consider urine volume because the more urine they produce, the more dilute it's going to be. So that's important as well. And this RSS, or this relative supersaturation technology, it's really a way to just assess the diet-specific risk that that dog or cat is going to form more uroliths or basically form more crystals that could grow into uroliths. So there's a few different zones or levels when it comes to this urinary saturation. Now, if a patient is oversaturated, the way to think about this is if you have a glass of water and you add abundant amounts of sugar to it, there's going to be so much sugar that there's going to be actual sugar floating around at the bottom. We would say that's oversaturated because you can actually still see a bunch of sugar there. Now, if we were to move to the opposite end of the spectrum with undersaturated, that would be like taking a glass of water and adding just a teeny tiny bit of sugar to it. So the sugar actually dissolves and you really just see clear liquid. So we would consider that undersaturated. And then in the middle here, we have this metastable range where we aim for minimal growth. You're not going to dissolve things in the metastable range, but for something like a calcium oxalate stone where we can't dissolve it anyway, that's where we would aim to be. With respect to struvite, we would aim to be in this undersaturated zone because that's where dissolution is actually possible. So how do we develop this relative supersaturation technology for dogs and cats? So we would take a number of animals, typically for one of these urinary trials, it's 6 to 8 animals. They would undergo an adaptation period where they were eating that specific diet that you wanted to figure out the RSS for. And then there would be a collection period where urine would be collected from anywhere to 2 to 5 days, depending on the particular study. Once urine's been collected, it's going to be analyzed for pH. They're also going to determine the volume of urine and all of the number of urine constituents. So all those factors that can come together to make a stone. And then there's some pretty fancy software that you can use to come up with a relative supersaturation number. So when it looks at urine pH and those different concentrations, these are some of the components that we're working towards looking at. So calcium, magnesium, sodium, potassium, phosphate, even sulfates, ammonium, oxalate when it comes to calcium oxalate, citrate, and even uric acid. So a number of things. And there's a few different computer programs that are used to actually come up with a scale for both struvite and oxalate. So you could have one particular diet being fed, and you could analyze for both the RSS value for oxalates and the RSS value for struvite. And if that diet comes to the right point on the scale for both of those, then that diet can actually be used for prevention of both of those stone types. So when it comes to relative supersaturation for struvite, I mentioned that we want to be in the undersaturated range or the undersaturated zone. And that means that we want an RSS value less than 1. When it comes to the metastable range, this means where growth would be minimal, but we're not going to be able to dissolve things. It's typically between 1 and 2.5. And then if the diet were to produce something over 2.5, that's where we're going to see more stone and crystal growth. I've already mentioned that with calcium oxalate, dissolution is not going to be possible, but if we compare relative supersaturation technology to just urine pH and the KNFs, or the key nutritional factors, these are some of the things that we would consider when we're looking at cat and dog foods for calcium oxalate prevention. So we're having more of a moderate calcium level. We're avoiding any excess oxalates. We're also going to avoid any excess of vitamin C because vitamin C can actually act as a precursor to become oxalate. So we want to be careful about, especially in dogs, feeding lots of rich vitamin C fruits and those sorts of things. The protein levels here, we don't really ever do low protein diets in cats being true carnivores, but you can see that the protein level can get quite low in dogs. And then the urine pH range is a bit more alkaline here, and obviously we want to increase water intake. I am just going to focus on a couple of the different sources of oxalate. So definitely we want to avoid extra vitamin C because it can be a metabolite. And we also want to avoid plant sources. So a lot of things that tend to have oxalates in them would be different types of whole grains, different vegetables. With meats, there aren't a whole lot of meats. Sardines are up there. But you'll see that lots of these different vegetables are listed as potential concerns. So we would want to avoid any of these vegetables that are listed as high oxalates and very sparingly use the moderate oxalate category. So an example of something that's a common treat now is sweet potatoes. So that would need to be avoided. Green peppers, green beans, even something like celery, which, you know, on the surface you think, well, that would be a pretty good treat if the animal would eat it. Well, not particularly if they're a calcium oxalate forming patient. And I have no idea why they've listed chocolate, coffee, and beer on this list. I think probably because it was taken from humans that form calcium oxalate stones, but please don't be feeding any of those to your patients. So, but just to give you an idea of some of the things that we need to avoid, we do have a list here because also we want to avoid very high calcium foods. So things like yogurt, cheese, different dairy, definitely want to avoid those sorts of things as treats for these particular patients. So there are quite a few things that are listed on here as options. I have to tell you, my go-to, if they will not feed, you know, the crushed up kibble made into little cookies, or they won't feed the canned food made into jerky, my go-to is usually something that's really, really high in water and is low in oxalate. So I tend to go with the melons, like the watermelon, the cantaloupe, and the honeydew, because most of it is water. They are going to get a bit of sugar there, so not going to be appropriate for a diabetic patient, but for the amount of water that they're getting, it's really going to, you know, probably increase their water intake. So that's usually the way I go if we absolutely have to give them something else. I have had owners crush up watermelon with water and then freeze that into little ice cubes in the freezer. So then in the summer, they have like little frozen watermelon ice cubes. You can also put them in a Kong, which works really well if you've got an animal that you've got to keep busy. So you come up with lots of tricks when people will not be compliant with your no treat recommendations. So here's what we would look for with the relative supersaturation approach for calcium oxalate. With this scale, it is a different scale than the Struvite scale because different components come together to make calcium oxalate. So less than 1 is going to be undersaturated, but we're not going to aim for that because, again, we're not going to be able to dissolve. So really you aim between 1 to 12, and there can be a really big range in there. Obviously, the closer you can get to 1, the better, but that doesn't say that a diet that's, you know, 9 or 10 isn't going to be effective if it's fed consistently. And then this would be oversaturated if the value that the computer produced was over 12. So I think this is probably a good way to look at it. We've got scales for both cats and dogs here, just showing that the top scale there is for calcium oxalate, and then the lower scale is for Struvite. We've got the same thing on the right here for cats, but just showing that the numbers are very different here, just because obviously dogs and cats are very different species, but also these two different stone types are very different. So we've got to pay attention to what type of stone is forming and how the diet's been analyzed. So when it comes to the take-home messages, the most important thing is going to be moisture, moisture, moisture. Do not forget that, okay? That's going to be the most important thing. Then consistency with respect to the diet. So feeding a diet that's appropriate for that type of stone that we suspect or that we know, because remember, every time you take out a stone, you're going to send it to the Urolith Center so that you can have an analysis and we can figure out what the nidus was. That's going to be very helpful. We're going to avoid treats. If they won't avoid treats altogether, it's better for you to give them a recipe to make a treat or do something that's really high in moisture content and low in oxalates to make sure that they're still being compliant. Otherwise, they're going to go and buy something like a pig's ear or go get a Timbit at the Tim Hortons drive-thru, and everything just went out the window. With respect to technology, definitely there's a possibility of using urine pH and key nutritional factors, but I want you to keep in mind that there's newer technology called relative supersaturation that can be very effective for multiple stone types. And then, of course, monitoring to make sure that the owners are being compliant, not only with the diet itself, but also making sure that, you know, they're not feeding too much or anything like that, because no nutritionist likes to see a patient packing on the pounds from their diet plans. So any questions? Yes.
It's not really a question. I just wanted to bring in something.
Yeah.
Bring in something. Just about the cranberry extract.
Oh, thank you. Yeah.
It's something that some people use to prevent E. coli infections.
Yes.
But definitely can be a concern if it has some side effects present.
Absolutely. And that brings up a really good point. So lots of the supplements that people will be feeding, I will get them to take a picture of the supplements so that I'll have the ingredients list, because it's amazing the amount of times that the supplement contains additional calcium, magnesium, protein, vitamin C, all those sorts of things that could really be detrimental. So supplements definitely aren't benign under these circumstances either. So I try to take a real minimalist approach where we start with just the diet and tons of moisture, keep it very consistent. Then if we're monitoring, doing our urine analyses, specific gravities, looking at the urine sediment, radiographs, doing ultrasounds, those sorts of things, and things are looking really well, and we're getting out to the point where, you know, we're 6 months to a year out. Then if the owner is really adamant about adding something, then I will say you can add one thing, and then we need to monitor very, very carefully, because I don't want you adding 6 different supplements and then all of a sudden we've got a whole bunch of stones forming and I can't tell you which potential thing caused the problem. So have them be very, very cautious, and you need to give it a good number of months, because some of these stones, I mean, even with struvite, if there's, you know, those can be rapidly forming stones, but with calcium oxalate, I mean, some of those can take years to reform. So we need to be really cautious about what we're adding to the diet, and continue that monitoring and let them know, well, if we do want to add something, that we might need to ramp up the monitoring again, because I don't want to miss something now that we've changed something when your pet was doing so well. Great point. Other questions? Yeah.
Just along the same lines there, what patients would you use a cranberry extract supplement on then? Because that's become something more commonly available in the market for us.
Absolutely, and it's not something that I'm currently doing. So I don't know if internal medicine has something, you know, the evidence in humans is really with respect to E. coli UTIs in women and the actual E. coli fimbriae not being able to adhere to the bladder wall. And we just don't know if it works the same way in dogs. So I'm erring on the side of caution and not using it right now, because my goal is to always do no harm. So I don't know.
So I would agree there's a difference between the dogs and the women.
Yeah.
It seems not to be very effective in to prevent the E. coli infection. So because so if definitely we don't really know, to be honest, but definitely if there is stone formers patient, then I will recommend not to use it, because the benefits will really not be very high in this case.
Good. Any other questions? All right. Well, I will stick around if you think of any burning nutrition questions later.
Hello, everyone. So we're going to change our topic, and now we're going to start talking about proteinuria. But before we start, I would like to do a small survey and to know who is doing routine urine analysis in your practice. So something can comparison to lab work with CBC and chemistry. How often do you do that? Do you do that as often or just a lot more rarely? So can someone raise your hand if they do very often urine analysis? Okay, very good. So the people that work with me, they will probably tell you that, yes, I'm very insisting a lot on performing urine analysis because I think it's very important, and at least a unit-specific gravity and a dipstick. And I will explain you why I really think this is important to have that as either monitoring my sick patients or even screening healthy patients in terms of proteinuria, mostly for now. So the importance of proteinuria that we know is proteinuria is associated to increased renal morbidity and mortality, but also mortality of all causes. So animals that are not azotemic, and especially cats that are not azotemic and they have proteinuria, they know that the survival is shorter than a cat that would not have proteinuria. So it's associated with development of renal damage and chronic renal failure, and it's one of the main causes of development of chronic renal failure, especially for dogs. The presence of persistent proteinuria is indeed associated with glomerular and tubular interstitial damage. So when these nephrons will be damaged, there will be more and more loss of nephrons, which will lead to chronic kidney failure. Unfortunately, once chronic kidney failure has occurred, the prognosis is quite poor. So what would be important is to be able to diagnose it before, because that would be the time where we could do something about it. So some consequences from proteinuria, direct consequences, will be development of nephrotic syndrome. So I don't know if you really know what is nephrotic syndrome. It's a combination of proteinuria, hypoalbuminemia, hypercholesterolemia, and fluid retention, like such as ascites or of subcutaneous edema. And other consequences that can occur will be hypertension from salt retention. So the kidneys really have problems to deal with the salt load and will retain a lot of water. So that's one of the mechanisms of ascites on top of having low albumin. And thromboembolism. So there are two mechanisms to explain thromboembolism. One of the big mechanisms is the loss of antitrypsin 3 through the glomeruli. Another mechanism will be activation of platelets and also frequent thrombocytosis associated with glomerulonephritis. And also we can see weight loss and muscle wasting. So a lot of things that can create proteinuria, and the one that we would like to target the most of glomerular and tubular proteinuria. But before that, we need to rule out other causes of proteinuria, which can be pre-renal or post-renal. So what is pre-renal proteinuria? So it can be associated with dysproteinemia. So for instance, when you have hyperglobulinemia, when you have hemoglobinemia, myoglobinemia, all of that can induce proteinuria. As well, when you have Ben-Jones proteins. So Ben-Jones proteins are very small proteins that are produced when with multiple myeloma. So they are light chain proteins. For post-renal proteinuria, so you will see post-renal proteinuria in case of urinary tract infection or inflammation from other causes, so stones, TCC, transitional serous-carcinoma. And in terms of hematuria, I heard a lot of people saying, yes, hematuria can increase your protein on your dipstick. I will have to say that probably if the urine is red, so if it's grossly hematuric, yes. Otherwise, I will tend to think that's not very likely, or at least not increasing the UPC. So once we have ruled out pre-renal, post-renal, so most of the time by doing a urine culture and doing evaluations such as the serum biochemistry. Then we're left with renal. And then there are 4 categories of renal proteinuria. So I'm pretty sure this is much more than you thought it could be. So one of the category that we don't really care about is called functional. So it's usually a low-grade proteinuria with a very low UPC, and it will be transient. That can happen following a strenuous exercise, fever, inflammation in your body. Another category is called interstitial. This one is easy to rule out. This is basically what you see with pyelonephritis. So there is an infection in the kidneys, and there is exudation of proteins within the nephrons. So usually you will have fever, you will have leukocytosis, you will have painful kidneys, and you will have an active sediment. So quite easy to rule out. Once you have ruled out all of the remainder, you're left with 2 big categories, and the treatments will be quite different. So one is glomerular and one is tubular proteinuria. So here is a little table to help you knowing which one could that be. One thing to know is the highest UPC is associated with glomerular disease for sure. So whenever a UPC is above 2, you can be sure you have ruled out the tubular causes or everything except a pyelonephritis or a urinary tract infection. So anything above 1, more likely glomerular, but for sure above 2. Tubular disease, however, has it's a persistent proteinuria. So if you repeat your analysis, you will still have proteinuria, but it's a mild proteinuria with a UPC between 0.5 and 1. Other findings that can help you to know if it's glomerular or tubular will be presence of cast. You can see hyaline cast with glomerular disease, but really most of the cast will come from the tubule. So cellular cast, granular cast, fatty cast, waxy cast. And the difference will be in terms of the complications. While you can see hypertension, nephrotic syndrome, and thromboembolic disease with glomerular disease, thromboembolism with glomerular disease, what you see with tubular abnormalities is quite different. You can find on your distic the presence of glucose, while the blood glucose is normal, and then that really will be consistent with tubular disorder. You can also see renal tubular acidosis. So that's a development of severe acidosis because the sodium, the bicarbonate cannot be kept, or because there is a problem with ammonium ion. And also loss of some of your electrolytes. So usually you can have a severe hypokalemia that is present. If you have a combination of loss of electrolytes, of renal tubular acidosis, and normoglycemic glucosuria, this is a syndrome that is called Fanconi syndrome. So about glomerular disease, you still have quite a lot of disease that can do glomerular disease. This is why you don't come up with one treatment for every type of glomerular disease. And it's important to realize that. So one of the main ones you probably heard about is glomerulonephritis, and it's an immune-mediated disease. But there's not the only one. You can have amyloidosis. Some breeds will be predisposed to that, like Sharpei, for instance, or Abyssinian for cats. You can have the Cushing's disease, will also lead to glomerular disease. And there is a lot of breeds, dog breeds, that are predisposed to what we call familial glomerular disease. And I will show you, there is a table with that. A lot of breeds will have that. You expect to see proteinuria earlier, if that is the case, so in young dogs, as opposed to other acquired disease that may occur later, and especially Cushing's disease, which will really occur later. Then, one of the main mechanisms for cats to develop proteinuria is glomerular hypertension. So that's kind of an adaptation of the remaining nephrons, so the ones that are still alive, that adapt to receive all of this, to produce all of this urine. So they are just use a bit too much, but it's a maladapted mechanism that lead to further damage of this nephron. So it's like a vicious circle, because they do that to compensate for the loss of renal function, but they are just killing more and more nephrons. So this can also occur from systemic hypertension when it's above the autoregulation. Autoregulation can occur with systolic pressure 160, 180 with no problem, but when it starts to be crazy above that, then you will have a loss of autoregulation. Some cases of chronic kidney disease can also, just by the kidney disease, have loss of autoregulation, and then you have glomerular hypertension. So one of the main mechanisms for cats. Rarely, and that's mostly a problem for people, you can see diabetic nephropathy, but it's rare for our animals, but not impossible. And then you can also see vasculitis in diseases as FIP, for instance. So glomerulonephritis, what occurs is that there is deposition of an immune complex, so formation of antigen and antibody complex somewhere, because there is an inflammatory process in the body that is just then filtered in the glomeruli. That, or they are formed directly within the glomeruli, however, in many conditions, we don't find this antigen. We don't find the source of the antigen. That doesn't mean we don't want to look for it, because if we find it, that probably will have a better success with our treatment. So once again, glomerulonephritis a lot more common in dogs than it is in cats. So just a bit of review about dogs and glomerular disease. So as I said, it's a common cause of chronic kidney failure. And in 2 studies, it was about 50% of the chronic kidney failure that was related to initially glomerular disease. So that's why, for me, it's very important to treat and to screen these cases before they develop azotemia. Many cases of glomerular disease secondary to systemic disease processes, so especially neoplastic, infectious, or non-inflammatory disorders. So the non-inflammatory disorders can be the non-infectious inflammatory disorders can be diseases such as inflammatory bowel disease, can be don't also overlook conditions such as pyoderma, chronic skin disease, or chronic dental disease. They are probably a good source of inflammation and infections. So in one study, 48% no causes that could be found, 20% neoplasia, 12% infection, and 50% with non-infectious inflammatory disorders. So here is a list of all of the diseases that can create glomerulonephritis in dogs. So quite a lot, and a lot are infectious causes, but a lot of the common diseases that we see. This is why, once again, I recommend to screen that on all of your patients that are sick as well. Here's another list of familial glomerulonephropathy. So most of these dogs will not benefit from using immunosuppressive medication. All of them, except maybe 2. So these 2, that will be the Bernese Mountain Dog and the soft cotton Wheaten Terrier. So basically for soft cotton Wheaten Terrier, what we know is that it's possible that protein-loading nephropathy occurs secondary to the protein-loading enteropathy, and definitely it has been found that it could be related to diet hypersensitivity, and we can control a lot of these early cases with just an hypoallergenic diet. The Bernese Mountain Dog also may have some immunosuppressive drug, could improve with immunosuppressive drugs. All the other cases, probably not. And then I wanted to talk about Cushing's disease and proteinuria. As Cushing's disease is a very common disease and very commonly associated with proteinuria. Probably about 70% of them will develop proteinuria. Or it can be either spontaneous or iatrogenic from using steroids. So what happened with excess of steroids is that there is glomerular and tubular dysfunction that we know for sure. So there is an elevation of the glomerular filtration rate, as well as development of systemic and glomerular hypertension. But it's definitely rare that chronic kidney disease will occur secondary to Cushing's disease, as considered as rare in our patient that it is in human. However, there are some cases of Cushing's disease that have been related to nephrotic syndrome, which once the Cushing's disease was treated, the nephrotic syndrome goes away. It has not been found in dogs or cats so far, but it's still interesting to know that it can happen. Proteinuria usually resolved after treatment because we drop the GFR and we improve the glomerular and the systemic hypertension. However, in the kidneys, there is definitely some irreversible development, such as development of focal glomerulosclerosis. So it's irreversible, it's fibrosis basically. And rarely you can see development of glomerulonephritis and amyloidosis. So you may wonder if that could have occurred in cases that the proteinuria do not resolve after either the steroids are stopped or either the Cushing's disease seems to be under control with medical treatment. What about cats? So glomerular disease in cats, not very common. The glomerulonephritis and the UPC that is very and high UPC are very rare. And I would say nephrotic syndrome is probably exceptional. So I would like to hear about it if you find one. So as I said, the main mechanism to explain proteinuria is probably compensatory glomerular hypertension from interstitial nephritis and then loss of the kidney mass. But what we know is that the proteinuria is a marker of disease, but probably also a mediator. So just having more and more problem with the kidneys. The presence of proteinuria and its magnitude is negatively affect the prognosis in both azotemic and non-azotemic cats. And the common cutoff that we use for UPC in cats is up to 0.4. But what we know is that the cutoff that will differentiate between the cats that will survive and the cats that will not survive when they're not azotemic is actually much lower. So there is a borderline zone of 0.2 to 0.4 when we'll already wonder if it's normal or not for that cat. So this is probably something that you all know about, all the tests to diagnose proteinuria. So the one that we use routinely is urine distic, and it's a great screening test because it's quick and it's very cheap. However, it has problems. It has relatively low sensitivity, so it won't detect anything less than 30 milligrams per deciliter, and also relatively low specificity. So especially for cats, they like to have a lot of false positive test results on that distics, or any dogs with a high specific gravity and a high pH will be way more likely to have a false positive. Another thing to know is that for animals that have a very dilute urine, even traces of protein may be a problem already. There is a test that some lab will do to confirm if the dipstick is normal or not. It's called a SSA test for urine protein sulfosalicylic acid precipitation test. Unfortunately, they won't do all the time. I don't know why. It's kind of like sometimes it is, sometimes it's not. The test is way more sensitive. It also would detect other proteins than albumin, so globulins or Baines-Jones proteins, for instance. It can be falsely positive with some drugs like TMS will falsely positive the test. And as I say, not always performed. The UPC is one of the main tests that we want to do because it gives us guideline, it gives us prognosis, and it gives us also an idea of what is the disease in this particular animal. As I said, high UPC, it will be glomerular. Either glomerulonephritis or amyloidosis will be more likely. So normal will be 0.5 for dogs, less than 0.5 and less than 0.4 for cats, knowing that between 0.2 and 0.4 for cats, it's kind of borderline and maybe already abnormal for some of these cats. The problem with UPC, and that is important to know, is that there is a lot of daily variation to the point that when we are assessing efficient, like if a treatment is efficient, we cannot tell until there is a difference of 40% of the UPC. Less than that, it can just be daily variation. In cats, it can be even worse. Within the normal range, to be sure that there is an actual variation that is abnormal, you need to have a difference of 90% of this UPC. So almost double before we know when it's not like within the normal range, that is, there is a change. So what I recommend is when you want to evaluate the UPC, that you do an average over 3 days. So you ask the owner to collect urine at home for 3 days, and then you do a mixture of all this urine, and then you'll have an average of UPC over the 3 days. So that will limit a lot of these variations that you can have. Another thing that is worth knowing is that UPC will depend on the renal mass. So if your azotemia worsen and you see an improvement of your UPC, it may not be super great. It may just be you don't have enough nephron left to actually excrete some proteins. Another test that I may not be the only one, but doesn't really know what to make about that yet, is microalbuminuria. So so the goal is to detect proteinuria when it's very, very small amount in the urine. So usually about one like few milligram per deciliter. So what we know is normal would be less than 1 milligram per deciliter. So we will use that in cases when we want a more sensitive or negative test. Maybe in some breeds that are known are predisposed to develop protein-losing nephropathy. So the breed that I mentioned already before. The problem is, if it's elevated, we don't have a lot of guidelines in terms of treatments to when we should treat. So that's a bit of the limitation with that, using that test. But for the UPC, we do have guidelines. So basically, so far, what we is recommended is for non-azotemic dogs and cats. We will monitor for a UPC between 0.5 or 0.4 for cats and 1. We'll start investigating about the cause, why they have proteinuria between 1 and 2, and we'll investigate but also treat when the UPC is above 2. We won't be, we will definitely be more aggressive for azotemic patients, because each time the UPC is normal, then we will start treating for these patients. So what will be the goals of the diagnostic investigation? So the first goal is to rule out any other non-renal cause of proteinuria. But then once we know it's definitely renal, then we want to know if we can do something different in terms of treatment, or if it's just the proteinuria is here because there is a disease that we want to know about, like a neoplasia, for instance. Like we know that lymphoma commonly associated with proteinuria, for instance. So routinely, we recommend to do thoracic radiographs, abdominal ultrasound, testing for infectious disease, and that will really depend for where you live. Here we kind of don't have a lot of infectious disease, so we limit ourselves to a 4DX SNAP test. But if there is travel history, then definitely probably it should be extended. And if it's indicated based on what we know from the animal, maybe testing for Cushing's disease will be warranted. And then we want also to detect and to look for sequelae, for consequences of glomerular disease, such as hypertension, for instance. So then we are left with, do we do or not kidney biopsies? So here you have to know that there's differences. There's kidney biopsy and kidney biopsy. So the kidney biopsy that if we run here, we will have available is light microscopy. And it's very good for different diseases. So if we have large kidney and we are worried about lymphoma, if we're worried about amyloidosis, we will definitely know if there is mesangial proliferation, if there is membranoproliferative glomerulonephritis. All of this we'll know. What we won't know, however, is if there is immune complexes. So if we have to treat with immunosuppressive medication or not. And for that, to have this answer, you need to have electronic microscopy. The problem is the cost, $1,000 if we send that to Texas, just for the biopsy. So not everybody will do that, for sure, but in some cases it will be warranted to do that. Not if they are already in end stages kidney failure, not if the kidneys are very small, probably in the cases that worsen despite appropriate therapy, and for our cases that has been developing very quickly. Azotemia has progressed extremely quickly. There are some, if we know about the underlying cause already, maybe like lupus in some of these cases, inflammatory conditions that we have found, probably not warranted to perform these biopsies. So about the treatment, so here is what will be the routine treatment of non-specific, just proteinuria with a UPC above 2. So diet, so first eliminate the underlying disease, of course, and then diet is important. So what we want is to have moderate protein restriction or marked protein restriction if there is azotemia that is already quite marked. Sodium restriction is important because that will decrease probably onset or help for your hypertension and also development of fluid accumulation and ascites. What we know also is omega-3 fatty acids are very important. They're here they can decrease inflammation within the kidneys and also will help with the platelets that are quite activated to make them just not as activated, I guess, just not decrease their aggregation. Two of the treatments that are important are the vasodilators. So we have two here, ACE inhibitors and angiotensin receptor blockers. So quickly, ACE inhibitor will inhibit this enzyme that converts angiotensin 1 to angiotensin 2, while angiotensin receptor blockers would actually block more peripherally the angiotensin receptor number 1. So an example of angiotensin receptor blocker is Sementra that has been used for cats. So what it does, there's multiple effects from your vasodilator. It decreases the GFR by dilating the efferent arteriole within that the glomeruli. So of course, one of the side effects can be increasing your azotemia and as well as problem with hyperkalemia. So that means that monitoring is really important whenever we start them or whenever we change those. It also will decrease intrarenal and mildly systemic hypertension. It will help for plasma concentration of LDL cholesterol and triglyceride. Will also help for glomerular hypertrophy and fibrosis, which is mediated by angiotensin 2. But there is a lot of cases when they're going to have development of an escape. So they will have peripheral production of angiotensin and aldosterone, so which one goes through renin, angiotensin, aldosterone system. So for these cases, when they become refractory to ACE inhibitor, maybe it will be warranted to either add an angiotensin receptor blockers or switch from an ACE inhibitor to an angiotensin receptor blocker. The reason why I say switch is because the recent studies in people have shown that adding angiotensin receptor blocker to ACE inhibitor, there is a lot of more people that develop severe azotemia, and they had actually higher death. So it seems that they are going back from adding to just switching now because of that. Another medication that could be added will be the use of spironolactone, so aldosterone antagonist. If these medications are not effective enough, the problem that you can run into is really a problem with hyperkalemia. Okay, so now we are left with the fourth treatment. So platelet inhibitor, very important. So we have either low-dose aspirin or clopidogrel. They are here to manage the risk of thromboembolism, but also to manage this activation of the platelets that occur because of the glomerulonephritis. So it's not only, and here this platelet activation are really a part of the pathophysiology of glomerular disease. So that can also help to decrease this negative effect that occur. So in terms of complications, so diuretics with effusions that can be used, spironolactone or furosemide, So you'll have to be careful with the potassium and be careful with the dehydration that occur. Management of hypertension, so adding a calcium channel blocker such as amlodipine to an ACE inhibitor if the ACE inhibitor is not enough. What happened? Okay. Yep. I'm not done. Okay, it's blocked. No. It is dead.
Maybe the clock.
So I don't know what I had after that. I need to remember. I think, it's back. Yeah, immunosuppressive medication. So I think there is a lot of questions. So when do we start immunosuppressive medication? And if we start, which one? So the first thing to know is, if we can have a biopsy that confirms there is an actual immune-mediated glomerulonephritis, it's probably worthwhile to try to have one. But in many of the cases, I would say most of the cases, we won't have it. So there are some guidelines to help you knowing when we should start that. So, no. I have it on my internet. I don't know if your laptop will work there. Come on. Do you want to open on yours? It's on the internet.
Yeah, we are going over time.
Okay.
Maybe, in a nutshell?
So basically, if you see a problem with progressive proteinuria despite appropriate treatment, if you see that they are severe right from the get-go, if you see that there is severe hypoalbuminemia, then it may be worth considering immunosuppressive medication. So what we know is that except in some cases when there is concurrent disease that will be treated with steroids, really the use of steroids, as you know, because it's already doing some proteinuria, is probably deleterious. So the recommendation will be to use mycophenolate for when a rapid-acting drug is needed, plus or minus prednisolone. And for stable or slowly progressive disease, and mycophenolate or clorambucil alone, or in combination with azathioprine, can be used. Otherwise, so monitoring and prognosis. So ideally, we would like to reach a UPC less than 0.5 for dogs and less than 0.4 for cats. The prognosis for non-azotemic animals is fairly good for these patients, and if they are non-azotemic or non-nephrotic. But in the category of azotemic nephrotic patients, then the prognosis is quite poor. I would say probably average is less than 3 months. So in conclusion, I would recommend to perform urine analysis in most of your cases, actually. The healthy one, the one that have chronic kidney disease and to monitor over time, the one that you wonder if you have to treat or not for hyperadrenocorticism based on what you know from the case, the one that are sick from other systemic disease. Do you have any questions? Yeah. Yes.
A lot of people interpret that as a cause of increasing protein on the dipstick.
Yeah, well, what I read is that it has to be red,
Okay.
the urine.
What's the cutoff before you would not send that urine sample for a PCR if there is microscopic hematuria?
So probably there are a few red blood cells. It would not bother me. Because, and it's quite often we see that because we have cystocentesis, we want to do a urine culture. So it would not bother me, and I will probably not interpret as this is the cause of the proteinuria. This is my opinion, and it will differ from with other people. What I've read is that there are other internists that wrote the same that I thought, so will agree with me that you have to have grossly hematuric urine before it change your proteinuria and your UPC. So I will not be bothered because there is 100 red blood cells on it. Yeah, but maybe other will have a different opinion. This is mine. Yeah. Yeah, this one will definitely be, so then if that is the case, because the proteinuria can definitely just be from the urinary tract infection, so you have to rule out post-renal causes before you think it's renal. So in these conditions, yes, it will alter, and then I will treat the urinary tract infection first, and then reevaluate later. But yes, it will. Good?
Before we wrap up, Alexa, do you want to share your baby in ICU? Don't worry, not an actual baby.
I said I have two slides, but I have 3 slides, and I have a picture. So I can show my picture.
Don't worry, it'll take less than 30 seconds.
It will, I promise. So, OBC has dialysis. Woohoo! Oh, everybody be excited. Definitely not. Oh, there you go. Well, I'll show you a picture. You can walk by on your way out and you grab an extra cookie or a little bit of lasagna for somebody that didn't eat at home. There you go. How's that? Huh? Yeah.
So what? Okay.
So we have gotten a dialysis machine in the ICU. It's a continuous renal replacement therapy. So I don't know, it's amazing how many people actually have family or friends who have been through dialysis. And what I think the general population is most familiar with dialysis is people who go in Monday, Wednesday, Friday, they sit through a 4-hour session, they have their dialysis and they go home. That is a type of dialysis that's fitting for people who have stable kidney disease and are healthy on their way in and out of their dialysis sessions. And what we've invested in instead in the ICU is something that's referred to as continuous renal replacement therapy. So it's this big green machine that I currently refer to as Shrek. And it is what's used in ICU settings across North America and Europe. It was developed in Scandinavia. And as its name implies, it's continuous renal replacement therapy, so it is performed 24 hours a day. So the patients are continuously hooked up to the machine, and it's a gradual reduction in the degree of azotemia. It's supposed to be more physiologic, better tolerated. We don't see the acute side effects associated with acutely dropping patients who have severe azotemia. We looked at, should we invest in hemodialysis or should we invest in continuous replacement therapy, and for some financial reasons, CRRT was more appropriate. And also thinking about our caseload of patients that we see. And so the types of cases that it's appropriate for and that we would consider would be animals who are presenting with acute renal failure, your severe leptospirosis, or they got into a bottle of meloxicam and they've ended up with renal failure, severe hypotension and sepsis associated or shock associated renal failure, grapes or lily intoxications, those sorts of things where what you're hoping is that you have this incredibly sick animal, but that you're hoping that you can take that animal through its acute crisis and have it come out the other side and not be reliant on chronic kidney failure therapy. Personally, philosophically, I'm not ready to take the geriatric ancient cat with chronic kidney disease and have it in Monday, Wednesday, and Friday indefinitely. So that's not the purpose of the type of dialysis that we've initiated at OBC. Effectively, it would be great for patients who have acute disease. You're not going to throw just anybody on the dialysis machine. The dialysis machine takes blood from an IV catheter in the jugular out to this system. It's outside of the body, extracorporeally cleaned and returned back to the patient. So there's always a portion of that patient's blood volume out here in the machine, meaning it's not in the patient. We have to anticoagulate the patient extensively in order to be able to pull the blood out. We're doing that 24 hours a day, so there's high risk of bleeding associated with the treatment. There's also the potential for lots of different complications because there's a pretty large blood volume, particularly when we're thinking about our smaller patients like cats. Large volume of their blood, 60 mils of blood is the smallest dialysis sort of unit that we have, so that would be about 1/3 of a cat's blood volume. Whereas the last patient that we did, and we've only done 2 so far, but they've both gone well, But the last one that we did was a huge big malamute, and the extracorporeal volume in a big patient like that, and the bigger circuits that we have is 90 mils, and the stop blood volume is 3.5 liters, so much more tolerable for larger patients. But just to consider patient size, the degree of azotemia, it's not a benign therapy by any stretch of the imagination, so we're really only considering it for patients who are severely azotemic, moving towards oliguria and urea, where we're not able to control their water homeostasis, potassium, acid-base status, and so they're really sick. They have to be somewhere where patients or owners have to be prepared to consider the costs, that a lot of these animals are going to need blood transfusions considering the volume of blood that's outside of the patient. And that we do have a small percentage of owners that are willing to go there. For me, the most interesting thing was our last peritoneal dialysis cat that we had. The owners had pet insurance, and the bill here was $20,000, and the owners paid $2,000 because of pet insurance. They have 90% coverage on their pet insurance. It's pretty freaking amazing. So these owners were like, well, yeah, we're game to try. So occasionally we're pleasantly surprised. Not all bills will be that high, but it is definitely, yeah, it is cost prohibitive to the majority of clients out there. By no means are we expecting this to be running 24/7, but just to let you know it's here. You may hear about it a bit more and you're like, who, what, yeah, it is there. Okay? Questions? Yeah. What are we quoting? So generally for the first 3 days of dialysis, we would quote anywhere from 7 to 10 or 6 to 8. 6 to 8, 7 to 10. It depends on the size of the patient. The smaller patients and the smaller units are all actually a lot more expensive. So for a big patient, it's considerably less expensive than a small patient. So when you're getting different prices, you're like, what the heck? It would be a small cat versus a large shrew malamute would have a difference. That's all. Just exciting.
Thanks everyone for spending your evening with us. Thank you for your referrals, and please keep in mind that we love talking to you on the phone or in person. If anyone has any individual questions, we'll all stick around for a few minutes. And otherwise, have a sweet
And someone has to walk by my picture down here.
Yeah,
That's all.
Okay, thanks everyone. Take a cookie. Look at the pictures. She's so junky.
I know, like there's some water in there.
Sorry.